Good morning, everyone. It's good to be with you. I hope everybody had a good first day at the course. We certainly had a great course getting to know you and getting to know the faculty here. I'm going to follow up my talk from yesterday, which was an overview of implementation science, by talking a little bit about some of the terminology, frameworks, and theories that we use to guide the process. And I'm going to go over some of the material that I went over yesterday just to help reinforce that. And then please feel free to interrupt me as we go. We've got a good group here, and I'm happy to answer any questions. So I'll start again with a little bit of an overview of implementation science terminology, reviewing some of the key concepts from yesterday, but moving beyond just to get a few additional terms. I think learning implementation science is in some ways like learning a new foreign language. There are words there that you may recognize, but they have slightly different meanings, and it's good that we talk about what those meanings are. Then we'll spend some time talking about theories, models, and frameworks, which are a very important aspect of implementation science, defining what each of them is, and giving some examples of what some of the common theories, models, and frameworks are and why we need them. And then we'll talk about the challenging question of how to choose among all those theories, models, and frameworks. So as we talked about yesterday, the definition of implementation science is the scientific study of methods to promote the systematic uptake of research findings and evidence-based practices into routine practice. And it's really this foundation of evidence-based practices, which can also sometimes be referred to as evidence-based interventions. So these are things that are designed to improve health outcomes, or sometimes now people will call them evidence-based innovations, novelties, new therapies, new diagnostics, other types of new behavioral therapies that may be introduced to improve health outcomes. And on top of that, we want to try to use implementation science to translate those elements into practice to get people to take them up. And at the same time, we want to contribute to the scientific study of this field so that the things that we learn about one particular area may then translate over into other related areas, so that we're really building that generalizable knowledge. Now, I've talked about implementation science, I've given a definition, but the reality is that we use lots of different terms around the world. And I thought I would use this little map just to give a few examples. You may know of some others that we could add on. But in the US, we commonly talk about dissemination and implementation science. This work that we're doing today is funded by the Fogarty International Center and the National Institutes of Health. That's generally the terminology that the NIH uses. But north of the border of us is another term, knowledge translation, which I think is also a great term. How do we take the knowledge that we have and translate it into practice? Across the pond in the UK, they commonly talk about complex interventions. And the WHO, which is shown here in Geneva, but really all over doing training and innovation all over the world, talks about operational research and implementation research as two additional terms. Another concept that I like to get across is that the knowledge translation folks up in Canada often further break down dissemination and implementation science into research and practice. And I think that's actually a really helpful distinction as well, because we don't want to only engage researchers who might be not on the front lines, but we also want to think about public health practitioners and make sure that what we're doing is relevant to them. So you can also think about dissemination science being divided into dissemination research and dissemination practice, and implementation science being broken up into implementation research and implementation practice. And D&I research kind of exists on a broad canvas of other terms that are often commonly used. And I found this diagram that was put together in this article from the Journal of Oncology Practice, a review article about implementation science, very helpful a few years ago. And that is that dissemination implementation research kind of exists here in this diagram, kind of at the center of a broad field of health services practice. So that would include care of people in public health settings, so public health practice. It would include clinical settings, so hospitals, clinics, where clinical care is given. That's the field of health services practice. And of course, within health service practice, there's a longstanding tradition of health services research. Health services research is quite general. It often doesn't deal with one specific disease, but thinks about how do we supply health systems? What types of human resources needs do we have? How do we build structures of care How do we think about quality? How do we pay for care? These are some classic topics within health services research. And implementation science exists within that, focused again, as I mentioned, on evidence-based practices. How do we disseminate those to people? How do we figure out how to disseminate to those to people? That's dissemination research. And implementation research, how do we actually get people to do those things in everyday practice? Two other terms, operational research. You saw that the WHO often uses that term, operational research. I think in this scheme, we might want to think of it as being a little bit outside this. It's still part of health services practice, but operational research comes from a branch of engineering that's focused on solving a specific problem. And a lot of the methods of operational research may be very helpful, but it doesn't necessarily have the explicit goal of creating generalizable knowledge that might influence other fields, let's say outside of the specific field of health that we're working on. And then the field of quality improvement, which includes the methods that we talked a lot about yesterday. Lynn kind of highlighted, particularly the use of rapid cycles of change, the so-called plan, do, study, act cycles. And quality improvement methods are very important, but they also may not have the generalizable goal necessarily of creating new knowledge. We also said that implementation science is a translational science, and it fits on a background of a broader idea of translational science, where we start out with basic ideas. Oftentimes these might be in the laboratory related to molecular functioning or physiology. They might use things like cellular studies and translate those into therapies that we would then want to use. In the field of implementation science, we might kind of have some basic ideas about how something would work and then do some early stage proof of concept studies. But we need that evidence of effectiveness, impact on health outcomes before we really get to the later stages of translational research with implementation science. And we said yesterday that it's an iterative process, that we may go first from research to practice, but also come from practice back to research. Some of the best questions may actually arise from the clinic, from engaging stakeholders. And really, we talked a lot about that yesterday in terms of the methods of the NITEX model. So this translational science is sometimes numbered, and in particular, translational type 3 and type 4 are areas that are thought of as implementation research. And for those of you familiar with designations of clinical trials, it's similar to phase 3 and phase 4 trials. This is a related idea just to kind of highlight that translational studies sometimes translational research also goes under some different types of names, like pre-intervention research, which might be this T1, T2 type translational research. And then as we move closer to real world relevance, we may want to do traditional efficacy studies, so phase 2 trials, phase 3 studies that are more real world sometimes, maybe more pragmatic, looking at effectiveness outcomes, so that's effectiveness research. And implementation research is on the far side of that. I think we also said yesterday that sometimes people will even do studies. We heard actually quite a few examples of studies that have both an effectiveness outcome and an implementation outcome. And we really want to consider that goal from the outset. So just a little bit more terminology in terms of efficacy studies, effectiveness studies, and implementation studies. One of the kind of confusing terms is that we may differentiate between interventions and implementation strategies. And this is, I think, was mentioned yesterday in Mona's talk. Jeff Curran, who developed the hybrid studies, is a dedicated teacher of implementation science and developed this slide a few years ago. And what Jeff Curran says is that the intervention or practice or innovation, these are all the same terms for the same idea, is the thing that we do to improve health outcomes. So this may improve quality of life, functioning, sometimes morbidity and mortality. That's the health practice that's going to influence a clinical or a health outcome. Implementation strategies often kind of are shown as existing on top of that. How do we get people to do the stuff that we want to do to get people to do the thing? So that's really about changing practice or changing behavior. Sometimes these are called implementation strategies. Sometimes they're called facilitation strategies. There are things sometimes even called implementation interventions, but they're things that we want to do to help people and places do this intervention, practice, or innovation. And then the implementation outcomes, which we'll get to in just a moment, tell us how well we do all of these things. And we said yesterday that there's something that may be missing from traditional effectiveness research, which is what is actually happening when you have an intervention that works and changes some of these health outcomes. If we don't know what's happening inside this box, what are the processes that led this intervention to be helpful? Things like, did people adhere to the intervention? Were they able to take their medicines? Did they have the support that they needed to get to clinic and do all the things that were helpful for them to improve this outcome? We don't know what's happening inside there, and the intervention does work. We're not going to be very successful at understanding how to scale it up because we don't know how. On the other hand, if we get a negative study, we may just discard that study, even though it's a perfectly good intervention that was not implemented in a successful way. So if the intervention doesn't work in that situation, we won't know why. So it becomes very important, even in traditional phase 2, phase 3 research, to think about making measurements of things like adherence and understanding how people follow along, what implementation outcomes are affected, in order to get more effective effectiveness research and then be prepared to translate that into practice. We talked a little bit about this implementation research outcomes framework or implementation outcomes framework that often goes under the name of Proctor's framework, which looks in the inside and tells us that in order to be able to know what happened in terms of changing those health outcomes, we need to understand how well the innovation itself was delivered. We need to understand what strategies were used, maybe to train or to orient. In the wonderful talk that we had yesterday from Barrico, she was talking about scaling up this new therapy, hard to tolerate therapy for drug-resistant TB. And there were 11 or 12 different things that they had to do in terms of strategies in order to be able to get that intervention rolled out into practice. Strengthening the laboratory, strengthening clinicians, having reporting systems, getting drugs from WHO. Each of these are components of a strategy that was really important to be able to implement this new therapy. And measuring this process, of course, is a key point, and that's the source of implementation outcomes. So everything up to now was review, and now we're going to go a little bit further than we went yesterday by talking about what are some of these implementation outcomes. Now, implementation outcomes framework, the quotation, the citation here from Proctor, highlighted roughly this set of implementation outcomes. I'll go through each of them, but I first want to kind of highlight that they may be measured at different phases of research. In the early phase, where you're maybe looking at the feasibility or possibility of developing something, you may be thinking about these perceived types of measures. So these are things like acceptability, appropriateness, and feasibility. We figure these things out by getting people's perceptions of an intervention. And we might do that just by talking to them using qualitative or mixed methods, or increasingly, we might actually have scales like satisfaction scales, or there's actually even 3 measures: the feasibility implementation measure, the implementation appropriateness measure, and the acceptability measure. So acceptability is how agreeable, palatable, or satisfactory is a particular intervention. Appropriateness kind of gets more at whether this is a good fit for the given context. Is it suitable? Is it a relevant technology? And is it compatible with the health system as it exists? So if you're rolling out, let's say, a new laboratory test for the diagnosis of an infectious disease in a resource-limited setting, that might not be a good fit if it requires, say, a continuous supply of electricity and a certain temperature. So you really want to think about whether something's appropriate for a certain area. And if it's not, you may need to adapt that particular intervention to fit better there. And then feasibility gets, of course, at whether it's just practical and can be implemented. Once you've established those elements, oftentimes that's the green light to move forward to actual implementation. And that's where you may want to measure these observed outcomes. And we'll talk a little bit later about some frameworks that can be used to kind of help you remember all of these. That's one of the purposes of frameworks, is to kind of act as a checklist to guide those measures. But for example, the adoption may refer to whether providers take up this intervention, often sometimes just casually referred to as uptake. So are specific clinics offering the new service, or specific providers offering the new service? Does it actually reach those participants, and do they accept it? Sometimes this is also called penetration, but reach, I think, is becoming the more common term. And then we have fidelity and adaptation, which I'll go into in a little bit more detail. The way that you can think of fidelity and adaptation is really similar to the way we think about adherence to a medication. But here we're talking about adherence to the overall package of interventions. And this kind of gets at whether we actually delivered the strategy or the intervention as it was proposed, the protocol suggested, or do we make changes along the way? Cost is pretty obvious. We need to know how expensive it is. Is it affordable? Does it fit within thresholds for cost effectiveness? Are the resources available? Can they be spread over a number of years? And then sustainability kind of gets at whether something can be continued over time. Another term that's used here is maintenance. And there are even some people who would say sustainability is actually maybe more of a perceived outcome. And if we want to actually talk about whether something continued to be taken up and followed, maybe we should call that sustainment. But some of these terms are used in different ways by different folks. So I'll just stop and see if people have any questions about these implementation outcomes. Does it make sense that we would have different outcomes that we might be interested in at different phases of a study, and that we would want to be able to measure these in some way, in a standardized way? Yes. You're absolutely right. I've used cost as a shorthand here for economic analysis. So that would include measuring the cost, measuring the effectiveness, looking at the ratio of those two, and using a variety of methods that may vary depending on what you're looking at. For example, sometimes we would want to look at the cost for a given additional outcome. For my case, I work on a lot of studies where we're trying to find people living with TB that haven't been diagnosed, and we want to get them started on treatment. So we talk about the cost per additional person started on treatment. But we can also think more generally about the utility. So can we improve quality of life by measuring DALYs or QALYs? And that's very helpful sometimes for comparing across interventions. Is this investment that we're making in TB, is that, how does that compare to an investment that we make in HIV or opiate agonist therapy or whatever? So, yes.
You mentioned your goal is to improve quality life. What challenges do you face to just, to solve, for example, HIV or test or conduct researches to just eliminate or cure this virus? In my opinion, quality life or life expectancy increment depends on such factors to cure, for example, high blood pressure or hypertension or something like that. Focusing such problems would be. And also, I have another questions on implementation studies. How do you conduct? What specific methods do you have to study this implementation of therapies, or I don't know. And do you have any specific methods, or you create methods?
That's a great question. Yeah. So to take your first question, I may not be the best person to answer the question because I'm not a health economist, but as I understand it, there are methods for sort of understanding and measuring quality of life based on surveys. And if those survey instruments are prepared well, which is something we always want to think about in implementation science, are they translated? Are they understandable? Are they validated in a particular setting? Health economists often accept that, but we know that health economics is challenging. A lot of times we don't have the precision of measurement that we might have in other fields, but that's often how people would try to do it. In terms of methods for measuring implementation strategies or implementation research in general, I think you're absolutely right. I mean, I think that's probably one of the biggest messages that we would want to get across about this course is that we have lots of methods that already exist in epidemiology and social and behavioral sciences, but we need to adapt them for our purposes. Denise just made a great point yesterday saying that it all depends on the research question that you want to answer. And oftentimes with implementation science, we may already know that antiretroviral therapy is very effective for HIV. There's lots of studies that have looked at that and examined it, or opiate agonist therapy is very helpful in helping people control their addiction and other related health complications. We don't need to prove that again in an implementation study. What we need to figure out is how do we actually deliver it to people? So this concept of implementation outcomes, you don't see effectiveness up here because sometimes we don't even need to measure that. Often we will still measure it, but we may be more interested in can we close these gaps? Because let's just say in a particular setting, people don't believe that buprenorphine works or that it should be given to people with opiate use disorder. And so in that case, we need to focus on adoption as our primary outcome. How do we get more clinics to offer that? How do we get them to sustain that over time? How do we get more people started on therapy? So really, I think implementation research is about adapting our traditional methods to work well for those questions. And I think you're going to hear a lot of examples of that throughout the day. Yes.
Thank you. How many implementation outcomes can be measured in one implementation study?
It's a good question. I don't think there's any specific limitation. It may depend on your resources and your focus at a particular time. I think what I would encourage, and we'll talk about this as we go along, is that if you're just developing an intervention for the first time, I think Lynn said this yesterday, if you're not sure if it's really going to work, you may want to focus on rolling it out sort of in one clinic. So we're talking now about strategies. I said interventions, but strategies that could get people to take up a new intervention. You may then want to focus on acceptability, appropriateness, feasibility. Maybe you'd want to measure some of these early stage outcomes like do people adopt it and does it reach people? And then only over time as you get the strategy kind of well-defined. Rick yesterday showed a slide where he talked about all of the 9 different things that you'd want to specify about what an implementation strategy is in terms of who it's targeting and how it works and all those types of things. Then you might want to think about measuring these later stage outcomes. But in principle, you could measure all of these if you wanted and if you didn't already know the answer. All right, great questions. Let's move on. So we're going to do one last kind of topic here on the implementation outcomes, and then we'll move to the theories, models, and frameworks. So we talked about fidelity being a measure of whether an intervention was delivered as actually intended or whether it was changed, that is adapted to improve its fit to a certain setting. And there may be specific things we want to measure. We don't have to measure all of these. But some of the things we might think about looking at is, did people follow the training protocol? So a lot of times with behavioral interventions like cognitive behavioral therapy, you'd want to do very detailed measures and observations, maybe not of every situation, but spot checking people to see if they're delivering it as recommended. Figure out the dose. Are people getting the amount that was shown to be effective in a pre-intervention study? Are we actually able to deliver that in a routine or real world setting? How well is it delivered? So do people use, for example, for a behavioral intervention, do they use all the components of the intervention? How do people respond to that? Do they engage with it? And is it kind of changing some of the things that we want to improve? Let's just say you have a training intervention. You'd want to make sure that people are acquiring the skills by doing maybe a pre-test and a post-test and showing that they can do what you actually want them to do once they go out into the field and do it. And then sometimes, as we talked about a little bit yesterday, measuring the mechanisms of change. Does people's knowledge improve? Did the stigma that they were experiencing before that was holding them back from disclosing the HIV test, is that kind of affected by the strategy that's being rolled out? And at the left, you see this picture of what's called the fidelity challenge. And I like to make the analogy when we think about fidelity and adaptation to cooking. Now, when you cook, often if you're cooking savory things, you can vary a little bit the ingredients. Sometimes you'd use a little bit more of one spice or another spice, add more pepper or a little bit less. But when you bake something, it's very, very important to have the right ratio of flour and sugar and yeast, and because you want that cake to rise and taste the same every single time. But you can change the decoration. I have a boy and a girl, and we decorate their cakes differently based on their preferences. Even though they're the same age, we make the same cake, we put different colors of icing on it. So that's a way you can adapt it to a specific individual. And I think that's a nice way of thinking about with an intervention, what are the core components and what's the part that can be changed or adapted. So I want to just close this section by asking you all, why do you think it might be important to use clear and consistent language or terminology in implementation science? Anybody have any thoughts about that? To speak the same language? Yeah, absolutely. Say again. For fidelity? Yeah, we want to make sure that if what we learn in one study can be understood for other studies. If we have this overriding goal, right, that we can translate knowledge from one field to another field, talking about the same things may be important. And when we talk about strategies, yes. Sure. Yeah, I think that goal of standardization is to help increase our knowledge and help people translate or replicate findings more easily by using the same terminology.
To compare, yeah. Just a quick question. I don't know if it's relevant here, but whenever there's a moment when cake goes bad, but so whenever you measure all this fidelity, dose, and you understand that it's not right, and so have you ever had any kind of implementation science where you failed? What did you do then? Like, because it's it has quite a big budget here. It's not easy to do all over again. Yeah. So in this cases, like, what do you do?
Absolutely. I mean, I think it's very, very important to embrace your failures in implementation science. You know, in general, in the field of research, sometimes we might be embarrassed if something doesn't go the way we want. The funder may be disappointed. The people that engaged and worked with you to roll this out might be disappointed that it didn't have an impact. But it's really important to use these methods to figure out why it didn't work. So I had an experience where we did a whole intervention that was using digital technology, and it was a big failure because we thought it was going to be easier to get people to respond to text messages and charge their phones and do all these types of things. And so we kind of had to go back to the drawing board, and we realized that other elements of the strategy that we're using, people really liked and they were engaging them well, but we just needed to package it differently and give some additional components, specifically some transportation, to kind of help it, that overall strategy work better. And when we repeated it in a subsequent study, we achieved the output that we wanted. So yeah, that's very, very important. It may also be important if you implement something well and the intervention doesn't work, to think about maybe this intervention isn't well adapted to this population. Maybe we need a different intervention for biological reasons or cultural reasons or whatever that might be. Yes. Yeah, I should have had a good example in mind. I mean, certainly we know that humans are different, and so let's just say in the field of TB, one of the most common drugs, there are different genotypes, and so some people metabolize the drug very rapidly and may have worse outcomes, and other people less well. And so maybe what we need to do is sort of measure those differences and adjust our dosing to fit people. That's a very kind of biomedical example, but if you give me a little time or maybe a chance to talk to my colleagues. Yeah. Okay, great. All right, let's move ahead and talk about theories, models, and frameworks and why we need them. So we said yesterday that there's different phases where theories, models, and frameworks may fit in: the planning phase, the implementation phase, and the evaluation phase. So again, a little bit of an interactive thing. I'm going to give a definition, and then maybe people can raise their hand and let me know whether they think, well, there's one definition for theory, one definition for model, and one definition for framework. So a deliberate simplification of a phenomenon, which is narrower than others, it's descriptive only. Does anybody know whether that's a theory, model, or framework? Just keep it in your mind, and then we'll go to the second one, and then we'll come back at the end. Second is a set of analytical principles or statements that are designed to structure our observations, understanding, and explanations of the world. It's descriptive and explanatory, both, not just descriptive, but descriptive and explanatory. And then finally, we've got a structure, overview, outline, system, or plan. consisting of descriptive categories, including concepts, constructs, and variables, relationships that characterize phenomena, and it is descriptive only. So any thoughts on what the first one is? Is that a theory, model, or framework? I hear some theory and some model. Because it's descriptive only, that's actually a model. So model is really anything that you want it to be. If you're drawing something on a napkin, on a chalkboard, or maybe it's a key diagram in your guidelines that explain how everything works, that can be a model. Second one is a theory. So this is actually descriptive and a plan explanatory. And then the framework doesn't try to explain things, it just organizes everything for everything else. So we talked about theoretical approaches used in implementation science, and we have these different options that we have here. So first are process models, which seek to describe or guide the process of translating research into practice. Second, we have determinate frameworks, classic theories, and implementation theories, which seek to understand or explain what influences implementation outcomes. So this is looking inside that black box and trying to figure out what factors at the individual, household, community, health system, or societal level might influence implementation outcomes. And some have more of an emphasis on organizations, such as determinant frameworks. The classic theories may focus a little bit more on individual behavior, and I'll give some examples of each of those. And then evaluation frameworks are pretty well named. They're just to help us evaluate implementation. So I'm going to give a few examples of process models. There are other types of models that you can create, as I mentioned earlier, but process models help us plan. I had a good conversation yesterday about this idea of implementation mapping, and Rick talked a lot about how do we pick strategies that fit particular problems. But for that, a process model might be to start by defining the implementation problem or the implementation question together with stakeholders. So we know there's something we want to do. It's a new therapy. It's been proven to work. But where are the gaps in its delivery? Sometimes this often it involves a walkthrough, like Lynn talked about, drawing on a map. How is care delivered in this particular setting? And at each step, what's breaking down? What might be some of the barriers and facilitators? So defining those target behaviors and practices and figuring out what the implementation outcomes are, measuring the determinants or barriers and facilitators. Determinants is just another term for barriers and facilitators. Designing an implementation strategy, and then implementing that and measuring the outcome. So this is a process model for implementation mapping. Another type of process model is a logic model. How many people have seen a logic model before? So pretty good showing here. Logic models are often popular with funders to understand how you're going to use the resources that they're giving you. And so early on, you may just be purchasing a lot of inputs and organizing a lot of activities. And over time, you want to turn those into specific outputs that would improve implementation and health outcomes, and that those would ultimately have some type of impact. And logic models are really a form of a process model, kind of moving from left to right, and kind of add in also some concept of the associations or how you're going to move from A to B. There's actually maybe even a little bit of an element of theory here, but a logic model is quite adaptable to different types of projects. Say again? It's like a roadmap, yeah. And I'm going to actually conclude this whole talk by coming back to the idea of a logic model, because I think it can be a very powerful way of combining lots of different theories, models, and frameworks. The EPIS framework, which I won't really describe, but it's one of the best known and most widely used kind of frameworks in implementation science, is kind of interesting in that exploration, preparation, implementation, sustainment, a little bit like what I showed earlier in terms of planning, implementation, and evaluation. This is a process model. And actually, if you learn about the EPIS framework, underneath each of these categories, there's going to be long lists of determinants. So there's actually a determinant framework, which is built into a process model. So what's a determinant framework? A determinant framework is something that seeks to identify factors that influence implementation outcomes. And the best known of these is the Consolidated Framework for Implementation Research. Those that were here yesterday heard about the rich tradition of the CFR. It goes back to this original idea of Everett Rogers, the diffusion of innovation, understanding the characteristics of the intervention itself over here on the left that make it easy to adopt or put into practice, the processes that might be necessary. Remember, I talked about mapping out in the clinic what's happening, the walkthrough of the clinic. That's really all about processes. And then understanding the characteristics of individuals, whether those are the people who we're trying to serve by delivering these health interventions, or whether they're the people that are actually implementing that. We've got the inner setting, which is the clinic setting and how everyone works together and interacts. And then we have the outer setting, which kind of captures these other levels of the social ecological model. So that's the consolidated framework for implementation research. And I think one of the most powerful statements of why the CFR maybe works so well is that you now see many of the other frameworks that are out there kind of adapting themselves to now bringing in this kind of multi-level inner setting, outer setting process model characteristics. They're bringing them into their own frameworks, including the EPIS framework. So that's CFR. Yes. Yes, great question. So in 2016, there was a large systematic review that was done that was looking at how people used the CFR. And what they found is that most of the time people used it after implementation. And I think that reflected the state of the field, that people were just learning about it maybe after they'd already done their study and they were trying to backfit it to their study. But increasingly, it was a conclusion of this systematic review was that we should use it earlier to plan. And you can use it for both planning and implementation. So an example of how you might use it for planning would be to understand whether a health system or a setting is ready to actually adopt implementation. So what are the characteristics that you need to deliver your intervention? Are those present? Are those there? So those might be things like just having the resources necessary to provide the service. They might also include an ability to change and adopt change. So having extra time that might be necessary to be ready to kind of take on something new, and having experience working together in a learning collaborative to be able to take that up. So it can be useful both pre and post to understand implementation. Now I want to spend a little time talking about theory. So theory is a systematic way to understand events or situations. Could also be thought of as concepts, definitions, and propositions to help explain or predict events that may happen. The way I described it to one colleague yesterday was that we've got a basic science for biomedical interventions. Theory can be very helpful for things that we don't understand, complex processes like individual behaviors or practices or the way that people work together in groups. Theory here is very powerful for that. Theories by definition must be generalizable to some degree. And although they're abstract by nature, they're not necessarily combined and they're not necessarily confined to a specific area. Now, there's kind of maybe a little bit of a controversy, I think maybe from people more on the practice end and people more on the research end. And I just want to kind of highlight what theory might potentially add, because there is growing evidence that including theory in your implementation planning and in your implementation study leads to more impactful interventions and for a more rapid rate of learning. Now, traditionally, we've probably implemented things just based on our common sense. We get some of the most experienced people that we can find. We have them be change leaders. Maybe they're clinical experts. Maybe they're public health experts. They're practical. They have certain heuristics for understanding how the world exists, and they can recommend how we might adapt our intervention to do things. Some of the best people might be creative, and they're able to adapt things to a specific context. They might rely on their intuition, and some of the knowledge might be implicit, and therefore it might be hard to understand. It might be inscrutable. In contrast with theory, we actually want to have a concept for what we're doing, and we may want to think in advance using frameworks like CFR or other elements about how we're going to go about something. We want to prescribe what we're going to be doing. We want it to be generalizable. We want it to be hypothesis driven so we can evaluate whether these approaches work, and if they don't work, we can adapt them, as we talked about for another time. And we want them to be testable. So those are some of the differences between theory and common sense. Yes, you were going to ask a question. Yep.
What What do you mean? I mean, I'm interested about this hypothesis-driven theory.
Mhm.
Like, what kind of I mean, what do you mean by theory is based on hypothesis? Are those hypotheses proven or not? This is my question.
Yeah, I think it kind of depends on the theory, whether it's a new theory or a theory that's been existed. But ideally, you want to state in advance what we're trying to do with an intervention. So, yesterday Rick was talking about how do you choose specific components for a strategy. You want to have some explanation for why you're including those. If it's because people lack motivation, you want to incentivize them through a pay-for-performance intervention. You would presume that by incentivizing people, they're going to better adhere to practices. Let me give a couple examples. So I want to say that the theories exist in a couple of different general categories. Some are theories that seek to explain the world and may not be necessarily tested, but it can help us kind of understand why people do things and why they don't do things. That's in contrast to a change theory in which we want to think about which strategies or messages might be used to kind of help something move forward. So some examples might be, an explanatory might be understanding why in an occupational health program an employee smokes. Maybe that is because they're addicted to nicotine and they've always smoked. Maybe it's because they have a stressful job and that nicotine helps them control that stress. Maybe it's a social factor, which they just enjoy going on a break from work and spending time with other smokers. On the other hand, we have a theory of change, which might help us understand how to get an employee to quit smoking. And there's different models, which I'll go into more detail, that help us think about each of those types of theories. I'm going to skip over this because I think I mentioned it yesterday that there's lots of different theories, but I'm going to give an example of two classic theories, the health belief model, which is an explanatory theory, and which is commonly used. And its premise is that behavior is influenced by the expected outcomes. So if I'm thinking about engaging in some practice that I'm being asked to do, let's say seek care for my addiction, I have to kind of evaluate the perceived threat of that addiction. Am I susceptible to the adverse health consequences, and how severe might those consequences be? And then if I do kind of change my behavior, what would be the benefits? What are the barriers to actually getting access to that? And what are the sort of cues to action that would help me make that step to have enough self-efficacy to kind of go ahead and follow that health positive behavior, let's call it. So an example of this is cancer screening. So any screening intervention kind of starts by people being referred to being evaluated. Maybe it could be a self-evaluation in some cases. Maybe they need to see a provider who has a specific type of expertise. They'd have to go through consent to understand what are the risks and benefits of getting screened. They get the results, and then they would hopefully follow up to have action taken on that, whether that's a follow-up screening or whether that's actually an intervention to evaluate and treat whatever is being screened for. And you can see here that the health belief model might help us understand where someone lies, and we could even potentially kind of interview them and ask questions to kind of understand that. And by understanding what some of those barriers, that might guide our health messaging to improve their uptake of, in this case, cancer screening. Another example is the trans-theoretical model, or the stages of change model. So this has a little bit different idea. This is the idea that it's not necessarily about the perceptions, but that change is a process. And we need to meet people where they are in that process. So are they at the pre-contemplation stage? Are they contemplation stage? Are they actually preparing? Are they taking action or maintenance? And this one's a common one used, let's say, for certain types of addiction behaviors. So here's an example of using the trans-theoretical model for smoking. And you can see that it's kind of highlighting where people are on this pathway of change. And certain types of interventions, such as motivational interviewing, might want to address certain types of interventions that can address people depending on where they exist. Now, is this model accurate? I'm not going to address that. I think there's a lot of controversy in the literature about whether it is accurate or not. But what I want you to recognize is that people have different theories about that, and that we could use implementation science to try to evaluate or address those. So the third theory, classic theory that I could talk about, is the theory of planned behavior. So this is a theory that the intention is kind of the key determinant of behavior. So do I intend to do something? Am I motivated to do something? And that might depend on having the right attitude towards the behavior that we want to follow, that we would understand the sort of norms in our community or in the health system about whether people believe that we should actually do this behavior or activity. And then does that individual actually have control over that behavior? So all the other examples I've been giving, I've been thinking about the perspective of the patient. I'll take a little bit different perspective here and think about a provider who we're trying to get to follow a guideline. In this case, we were trying to get the providers to follow guidelines for screening, diagnosing, and treating people with tuberculosis. And we recognized that there were a number of predisposing factors in the environment, such as kind of a lack of knowledge about the intervention that we were proposing to deliver. And so by training people on the standards of TB care, the so-called ISTC, International Standards of TB Care, and then giving them a refresher training on how to do the key diagnostic test for tuberculosis, at that time, microscopy, we were hoping to improve that intention to follow the evidence-based guidelines. And then we also included some other interventions to enable them to better adhere to those guidelines, specifically a form of microscopy that took a lot less time and was a lot more powerful, called same-day fluorescence microscopy. And then we reinforced that by giving positive feedback when they did things well. We showed them what their performance was at baseline and how it improved over time. And we used that actually very successfully to increase the proportion of people detected with TB and started on therapy. So this is an example of taking a classic theory, the theory of blame behavior, and applying it now in a new context of implementation science to try to create an impact. So some of the limitations, and I'm going to run maybe about 5 minutes over, about 5 more minutes. I think probably the biggest limitation of theories and models is that behavior is complex, but models are intentionally simple. And many of these traditional models are not necessarily internally coherent or comprehensive to allow us to use them more generally. And very few of them link to an overall overarching model of behavior that considers not just the individual, but also the community or environment that they're working in. That said, some models are useful, but let's kind of conclude this talk by just discussing some of the frameworks. So evaluation frameworks seek to understand what is and what is not being implemented by understanding the fidelity and other implementation measures. And I'll skip over determinant frameworks because we already talked about that. So the premise of evaluation frameworks is that understanding implementation measures and process outcomes can help us better deliver those. And the classic model for this is the framework for this is the RE-AIM framework. Now, the person that developed this, Russ Glasgow, has a good sense of humor. And what he says is that probably they should have called it the ARIEM, the ARIEM framework, but that doesn't sound as good as RE-AIM. And the reason is that the RE-AIM framework is really about cascade thinking. How do we think about one step leading to another, leading to another? So traditionally, when we focus on effectiveness, we may only focus on one step, let's say the therapy, but we know that interventions are delivered over multiple stages. So we need to get all providers to adopt and deliver in relevant settings that intervention. We need to reach the individual, screen all of them, get them referred, get them on therapy. We need to implement this well, i.e. in a timely fashion, in order to have an effective intervention that can be sustained over time. So an example of this was a study that we did of the delivery of contact tracing during the pandemic. And what we found was that we didn't do a good job of reaching cases. There were big drop-offs at each stage, from the case being reported to the public health authorities, the case being telephoned, and the case being interviewed. We lost more than half of people. And then when we tried to get to the contacts, it was even more difficult. We missed almost 2/3 of them at the very first step. And to do this took enormous periods of time, way longer than we wanted to. We wanted to do this within 1 to 3 days, but many times it took up to 10 days to be able to do that. So we completely missed our window of opportunity to prevent transmission. So now we can kind of see, but a low level of reach and a poor implementation led to a low effectiveness of that intervention. And if we could actually intervene and change each of those, we might actually hope to improve that implementation. Finally, adoption, while we had many volunteers who wanted to sign up to help, they didn't last very long. The average period of time that they stayed with us was only a few weeks. And so this kind of helped us recognize that volunteers were not a good way to deliver this particular intervention. forward to kind of do interviews and focus groups to kind of figure out at each level of the REAIM framework, where were there gaps and how could we intervene to potentially address those, which we made recommendations that were used to kind of improve the way contact investigation was delivered. So I think the last thing that I want to talk about, I'll skip over the implementation research model and these reflection questions and just close by talking about how do we choose a theory, model, or framework. So this is a seminal systematic review that was done back in 2012 of theories, models, and frameworks. And basically it kind of identified that was really a need for standardized terminology, which you've kind of highlighted earlier, need for better comparative measures of theories, models, and frameworks, and for information about how to select among those. And that led to this systematic review that was done a little bit later to kind of identify, sorry, not a systematic review, but a survey of providers to kind of ask them, how do you choose among theories, models, and frameworks? And people were freely admitted that their choice of models was often haphazard or driven by convenience. And so what they concluded was that having a reason why the choice was appropriate for the problem was really kind of key, and choosing an approach that was familiar to individuals and to that audience. So I think because of time, I'll stop and not go further on this, but perhaps maybe a good topic for the Q&A is how do we choose among theories, models, and frameworks? And what questions do you all have about their overall use? Thank you.
Thank you so much, Luke. We are exactly on time, but still, I think we might have one or two questions if there is. Yeah.
I have a question about logical models. How do you, optimize using resources very optimally? I mean, use as few resources as possible effectively. So that's my question.
Yeah, great question. I mean, that's probably one of the most challenging aspects of implementation because, traditionally we would think about just costing the intervention itself, but with implementation science, we have to think about the cost of the strategies, and often training and reinforcing that training over time. It's expensive both in terms of time, and time may be limited many times when working in a public health setting. Resources may be limited in terms of the people of the experts, and certainly money is limited. So I think it's important also not to rush ahead too quickly because it takes time to figure out what works and to measure that and figure out which of the components of a strategy are really essential. So that's the cake, and which might be able to be adapted, the icing on the cake. So a lot of times we may have to figure out, look, we can't do all the bells and whistles we want. So let's just do the cake, because the cake is actually what's changing the outcomes. It's getting people to adopt things, and the other things may not be necessary. So it's really about measuring that efficiency using frameworks like REAIM and figuring out which things are actually changing the implementation outcomes that you're interested in and which things are not necessary. Great question.
I have a question.
Yes.
Okay. You showed us, and we've seen it yesterday as well, this, I don't know, pipeline of research, and then, preclinical efficacy, effectiveness, and then implementation comes. So I have a maybe stupid question, but it bothered me from the very beginning when I just first learned about what is implementation research, what it is about, or so. And I still don't have answer to this question. How do you decide when implementation study is needed and when you can go without it, just immediately do the effectiveness? Okay. Are there any criteria, or is this intuitive? You have.
Yeah, great question, David. And I think it gets at what do we mean by evidence? So when does something have good enough evidence? And I think that really, it's very relevant to implementation science, but it's actually a field of its own, this concept of evidence synthesis, and getting also, I think, buy-in from local stakeholders about whether something should be adopted. So yesterday, Mariko was talking about this kind of new therapy for drug-resistant TB. And what we knew about it was that it worked in one trial and it had amazing results. And so WHO, 2 trials, and WHO reviewed that evidence and made a recommendation, but there was no guideline that existed in the Central Asian region and Eastern Europe region to kind of adopt that. So operational research was undertaken to gather more effectiveness data and also to gather information on implementation. So I think oftentimes we're between effectiveness and implementation, and we may want to think about doing hybrid studies that will collect information on both. And a big part of it, I think, is not just, you know, all these methods of saying, is this high quality evidence or moderate quality evidence or low quality evidence, but thinking about, is it a good fit for the setting where we're working? And do you have buy-in from local stakeholders? And that can help you figure out where you are on that spectrum.
Thank you. Thank you so much.